and gentlemen, good morning, China. Good evening, USA. I'm Li Yan from Chinese Anti-Cancer Association. Welcome to the 4th China-US Anti-Cancer Summit, organized by China Anti-Cancer Association, US Chinese Anti-Cancer Association, World Association for Integrative Oncology. Next slide, please. And co-organized by eChina Health. First, let's welcome Vice President of China Anti-Cancer Association, Professor Ying Wang, to make opening remarks. Professor Wang, please.
Thank you, Dr. Yan. Dear presidents from CACA, AACR, ASCO, and ACS, and dear experts, and ladies and gentlemen, good morning and good evening. It's my great honor and pleasure to deliver the opening remarks at the 2024 China-US Anti-Cancer Summit. On behalf of the China Anti-Cancer Association and the World Association for Integrative Oncology, I would like to extend my sincere thanks to USCACA and eChina Health for jointly hosting the world-leading event. To share and improve cancer care, CACA works closely with leading cancer organizations globally. In December 2022, we successfully hosted the first China-US Anti-Cancer Summit in collaboration with AACR, ASCO, and ACS, which attracted 5 million audience online worldwide. Following this achievement, we held the 2023 China-US Anti-Cancer Summit with 16.38 million visits online. Meanwhile, CACA has jointly held international anti-cancer summits, including with Europe, Australia, Latin America, Africa, Canada, Singapore, Nepal, Tajikistan, and the UK. These events have attracted 190 million viewers online from 42 countries. Last month, we successfully held the largest cancer congress, 2024 Chinese Congress on Holistic Integrative Oncology, in conjunction with the 4th International Congress of the Asian Oncology Society in Xi'an, China. This conference brought together over 16,000 participants, including more than 5,000 invited speakers from home and abroad. The live broadcast reached 260 million viewers. During the conference, we held the inaugural General Assembly of the World Association for Integrative Oncology, in short, is WELL. WELL is a new global organization that was launched in China in 2023. Currently, WELL has 120 members from 70 countries. Today, we are pleased to collaborate with US leading cancer organizations, AACR, ASCO, and ACS, to jointly host the 2024 China-US Anti-Cancer Summit. I believe this event will unite professionals from China and the US to work together to facilitate academic exchanges and international collaboration. I believe by working hands in hands, we will make contribution to the global cancer control. Finally, I wish the 2024 China-US Anti-Cancer Summit a great success. Thank you.
Great, thank you, Professor Wang. I cannot believe it's already been 4th year since we started this US-China Anti-Cancer Summit. Thank you for your support. I know you really is the one who started this together with our association. So congratulations. Now we will begin our keynote speech session of the summit. I'm really delighted to welcome our first speaker, Professor Patricia LoRusso, President of the American Association for Cancer Research, AACR, and her presentation is Cancer Research Progress in the U.S. Dr. LoRusso, please.
Thank you, Dr. Yan. I just have to get my slides.
Yeah.
There you go. First of all, I would like to thank the organizers for inviting us to present to you today. And I'm just going to give you a brief overview of cancer research progress that's been made in the United States. To begin with, I'd like to just tell you, because I'm the president of AACR and represent the AACR at this meeting, that our mission is to prevent and cure cancer through research, education, communication, collaboration, science policy and advocacy, and funding for cancer research. Our membership is rapidly increasing, and currently we have over 59,000 members in 6 individual membership categories that reside in 142 countries and territories around the world, with 32% of our membership residing outside of the U.S. and 7% residing in international countries with emerging economies. There are over 31,000 associate members that represent over half of the membership, and associate members and student members combined represent about 57% of the membership and 62% of individual membership. We have many specialty meetings throughout the year, but the AACR holds an annual meeting, and in 2025, the meeting will be in Chicago between April 25th and 30th. Our theme is Unifying Cancer Science and Medicine, a continuum of innovation for impact. And as you can see, our 2 co-chairs are Dr. Matthew Vanderheiden, who's the Cancer Center Director at Massachusetts Institute of Technology, and Dr. Lillian Su from the Princess Margaret Hospital in Ontario, Canada. One of our programs is the Global Scholar and Training Awards. It actually started in 2016 as the African Cancer Researchers Travel Award, but in 2019 became the Global Scholar and Training Awards. It provides 15 travel awards to help early career investigators from LMIC economies attend the annual meeting. And in addition to that, these recipients can also participate in networking, mentoring, and global engagement events at local cancer centers. This year, those cancer centers will be in Chicago. We currently have over 100 investigators that are alumni, representing 24 countries, and they receive quarterly career development webinars. We also recently launched AACR on campus with the mission of defeating cancer through global education and training programs. These programs are one-day educational programs. The topic is typically chosen by the institutions that are hosting the meeting. And then we have an additional half-day meeting going over publication issues, membership issues, as well as networking. When we typically go into lower or middle income, low resource settings, we attempt to travel to 1 to 3 cities throughout the course of the week. Examples are one that was recently held at the end of October in Mumbai, India, and that topic was lung, GI, and breast cancers. And most recently, we had one in February 2024 in 2 cities in Brazil, where the topic was fostering connectivity amongst basic and translational research and clinical oncology communities for improved cancer patient management and outcomes. At each of these presentations and each of these day meet seminars, there are roughly 100 to 200 participants, often young investigators at the respective cities and institutions. We also have a grants program, and since 1993, we've distributed over 100,000 grants totaling in excess of $529 million to 27 countries. We have 10 scientific journals that we publish. The most recent, as you can see here, is Blood Cancer Discovery, launched in 2020, and also Cancer Research Communications, which is a dedicated open access journal that publishes meritorious research across a broad spectrum of topics. One of the highlights that AACR is noted for is their annual Cancer Progress Report. They have been publishing this progress report for 14 years. This is a very important progress report because it's accessible to government officials, various organizations, policymakers, to help update people on the progress of cancer throughout that year, not only nationally, but also internationally. So let's talk about some of the status, some of the progress of cancer research today. So within the progress report, and the following slides have come out of that cancer progress report, you can see that the impact of U.S. taxpayers' investment has been significant. In 30 years from 1991 to 2021, we've seen a 33% reduction in the overall cancer rate that equates to 4.1 million lives saved. And in 50 years from 1971 to 2022, we have seen a significant increase in cancer survivors. In 1971 being 1.4% of the population, and in 2022 being 5.4% of the population. In the last year alone, we've also seen significant progress. Between July 1st, 2023 and June 30th, 2024, the FDA approved 15 new anti-cancer therapeutics for various cancer types in the United States, and an additional 15 new indications for previously approved anti-cancer therapeutics. Additionally, there's been one new imaging agent, 2 minimally invasive tests for assessing inherited cancer risk or for early detection of cancer, and artificial intelligence has led to several AI-based tools that have been approved by the FDA for early detection and cancer diagnosis. And as you can see here, a very busy slide, but these are the 30 drugs that are either new drugs or for which there were new indications approved within the last year alone. We've also seen significant progress in childhood cancers. As you can see, between the mid-1970s and 2012 to 2019, both children at birth through age 14, as well as adolescents between the ages of 15 and 19, have had a significant increase in their 5-year relative survival rate. Accompanied by that increase in 5-year survival rate has been a significant decrease in overall cancer death rates in those two subsets, age groups of children and adolescents, with, as you can see, a 70% reduction in cancer rates in this 50-year span in children from birth to 14 years, and 63% decrease in cancer death rates in adolescents between the ages of 15 and 19 years old. We've also seen significant milestones where identification in the bench has led to novel FDA-approved targeted therapeutics to treat our patients. In 1950, the first neurotrophin nerve growth factor was discovered. It was later identified in 1998 as having a fusion. The first NTRK fusion was identified in infantile fibrosarcoma. The development of the drugs to target TRK have been very interesting because they were approved for all age groups. They were not only developed and approved in adults, but included many pediatric populations as well. The first drug, entrectinib, was entered into the clinic, as you can see, 62 years after NGF was discovered. And within a 14-year span, not only was entrectinib FDA approved for NTRK fusion positive solid tumors, but there were also 2 other TRK inhibitors, larotrectinib, as well as repotrectinib, next generation agents approved for these same tumor types. Precision medicine has come to the forefront. Patients diagnosed with cancer are really no longer generically thought of, but more so precision or personalized in their cancer profile as well as their cancer journey. We incorporate not only tumor itself and sequencing and various other biomarkers, but also many other known factors that contribute to the uniqueness of each person and their cancer. And patients' profiles are now determining the best treatment strategy. Medical research is also cycle driving progress against cancer. No longer is it just scientists working at the bench independently, but as they develop therapeutic agents and novel biologic strategies, they try to, as quickly as possible, incorporate them into the bedside. But this is bidirectional because what we identify in the bedside and hopefully the tissue samples that we obtain go back to the bench to help then with the continuum of the cycle of even better therapeutic strategies, which hopefully will then translate into standard of care therapies for our patients. And also, as we become more complex in the science of cancer and cancer treatment, both standard of care as clinical research, we recognize the need to help patients navigate through their cancer journey. We've identified in this country that there are many benefits of navigators. Patient navigation bridges a variety of gaps and addresses diverse needs across the entire cancer care continuum, from helping patients understand the importance of prevention, the importance of early diagnosis, to helping them through their treatment journey. And what we've identified is that it improves access to screening, patient care coordination, symptom management, and follow-up care, as well as reducing the cost of healthcare by reducing emergency room visits and missed appointments. They navigate these patients not only through their journey, but help them educationally better understand the entire process. The long and short is that patient navigation can also help reduce financial toxicity for our patients with cancer. But even though we've made significant progress, there are still many challenges. At one of the forefronts are the cancer risk factors. 40% of all U.S. cancer cases are attributable to preventable risk factors. Cigarette smoking, as you can see, leads the pack. But there are also many other significant risk factors, excess body weight, as well as alcohol consumption. We hope that with some of the GLP-1 targeted drugs, we may be able to overcome some of the risk factors and some of the cancers associated with obesity. But time will tell, and clinical research needs to be done to be able to answer those questions. We've also seen in the United States a significant increase in early onset colorectal cancer, a 3.2 increase per year of colorectal cancer in people under the age of 50, as opposed to patients over the age of 65 having a 2% decrease in the incidence of colorectal cancer yearly. And as we have an increase in the cancer incidence, unfortunately, we also see an increase in mortality of those that are younger than the age of 50, with a 1.1 increase every year, as opposed to the older age group of 65 and older that actually is seeing a 2.5% decrease in mortality every year. We have to begin to understand this, both from the biology as well as the clinical perspectives, and hopefully prevent this from increasing further, and hopefully changing the trend to decrease the incidence in this population. Unfortunately, in the United States, there's a significant prevalence of obesity. And as you can see, approximately 30% of all patients in the United States are categorized as being obese, with the greatest incidence, as you can see, in the Midwest as well as in the South. Alcohol is a cancer risk for many cancer types, including colorectal, breast cancer, certain types of head and neck cancer, liver cancer, and esophageal and stomach cancer. The HPV vaccine has made a significant impact on decreasing several HPV-related malignancies. We now know that there are 13 strains of human papillomavirus, or HPV, that can cause cancer. The US CDC has made significant and their advisory committees have made significant recommendations on immunization practices. 2 doses of the HPV vaccine given 6 months apart for adolescents younger than the age of 15, 3 doses for adolescents 15 and older to 26 years of age. And in those patients and in those people, the population that has never seen an HPV vaccine before the age of 27, it is recommended that this be a shared decision-making between the patient and their physician. And although there are 3 FDA-approved HPV vaccines, only one is currently being distributed in the United States, Gardasil 9, which protects against several of the human papillomaviruses. And the FDA has approved this vaccine for the prevention of anal, cervical, head and neck, vaginal, vulvar, and precancers, as well as genital warts. And it's recommended vaccination of males and females ages 9 to 45. Cancer screening has also been recognized as being extremely important, and it is not only a one-time deal or one-time screen, but it has to be a continuum and a constant dialogue between the patient and their healthcare provider to continuously screen based on screening recommendations. And if abnormal findings are identified, it is extremely important that they recommend follow-up, because suboptimal follow-up will unfortunately lead to late-stage cancer diagnosis. Looking into the future, I think the future is extremely bright. There are many, many tools at our disposal. I think that the Nobel Prize given to the 3 members in the Nobel Prize for Chemistry this year has the potential of making a huge impact. Understanding the unfolding of proteins can lead to potentially many new therapeutic interventions or tools in the future. But let's just talk about a few of them. Liquid biopsy, as an example, has become a new frontier in the early detection of cancer and can detect cancers from a variety of materials: blood, urine, spinal fluid, and other body fluids. The promise of liquid biopsy is that it may help detect multiple cancers early and simultaneously, and also it reduces potential physical harms of other medical procedures that may be needed or have been needed previously to help make those diagnoses. It can minimize toxicity because it's just a blood draw, and hopefully will overcome certain structural barriers. But it is still in developmental stages, and in many different facets, it is still investigational. And we do know that there are potential drawbacks. For instance, it could lead to higher rates of false positive findings with unnecessary follow-up procedures. It may not capture early stage cancers. Even in cancers that are advanced, liquid biopsies may not always be able to tell you what the genetic or variation is within that specific tumor. Now, it may not yield the same benefits for all populations, because we know that ethnic minority populations have not been well represented to this point in the trials with liquid biopsy investigation. So there is an unknown frontier as to whether or not what we've identified with the Caucasian population will translate to these other populations. And unfortunately, minoritized and medically underserved populations may not have access. Artificial intelligence is also becoming more and more important. As I stated, the Nobel Prize in Chemistry was given to 3 people for the development of AlphaFold 2, the first time a Nobel Prize was given for an artificial intelligence type of tool. And there's a lot of promise with artificial intelligence in terms of accelerating detection, reducing workload, and hopefully optimizing electronic health records to be able to give us better intervention and knowledge in treating our patients. But again, there are many drawbacks. They could potentiate data biases, especially if the AI algorithms do not include diverse populations. They could also promote cultural bias and unfortunately increase cancer disparities, again, predicated on the equitability of accessibility of these novel tools. So we at the AACR and everybody in oncology, I hope, envisions a healthier future for all cancer patients through clinical research. We know that cancer diagnostics are becoming more sophisticated. Artificial intelligence-based approaches are beginning to transform cancer detection, diagnosis, treatment decision-making, and response monitoring. Hopefully, convergent science, where we bring many disciplines together to leverage astronomical amounts of patient data, is becoming an important aspect of cancer research for more in-depth and integrated understanding of disease and for developing the next generation of drugs. Funding is extremely important. In the United States, the federal government funds a significant amount of research. Continuing this research, we know, is pivotal to progress against cancer. We've made amazing strides against cancer, and we hope we will continue, and we know we will, if we continue to maintain our investment in medical research. Thank you very much for your attention.
Oh, great. Thank you, Dr. LoRusso. And a comment to AACR as an organization to bridge basic cancer research, translational medicine, and clinical research. I remember many years ago, AACR, we didn't have any clinical trial presentations, but now we go to AACR annual meeting. There are so many first-time big trial data discussed, disclosed the first time at AACR. So thank you so much. Now it's my pleasure to move on to our next speaker. Our next speaker is Dr. Fan. Professor Fan is the president of China Anti-Cancer Association, CACA, president of Asia Oncology Society, AOS, and newly elected president of World Association for Integrative Oncology. So congratulations, Professor Fan, for your new post with Will. Professor Fan is going to discuss development of holistic integrative management of cancer in China. Welcome, Dr. Fan.
So, dear Chair Ying, dear all my colleagues, just right now, the Professor LoRusso delivered a very interesting and also impressive presentation on cancer control, the strategy and the results in USA. I'm sure China will get the benefit greatly and comprehensively from USA. I'm also very pleased to attend this summit to share our latest contribution on holistic integrative management of cancer. As you know, China is a big country with huge population and also the bears heavy cancer burden. According to the statistics, about a quarter of the world's cancer patients and 1/3 of cancer-related diseases are from China, with approximately 8,000 cancer diseases occurring every day. While the 5-year survival rate of cancer patients in USA is about 70%, it is around 44% in China. Standard diagnosis and appropriate treatment are crucial for improving overall cancer outcomes. Making guidelines is essential for effective cancer prevention and treatment. Tailoring the guidelines to meet to meet the needs of different countries is essential due to variations in diseases, etiologies, and population characteristics. For example, liver cancer ranks as the second cause of death in China. In the West country, for example, in the USA, its primary cause is HCV, hepatitis C, while in China, it is mainly caused by the HBV, hepatitis B. HCV is curable with antivirus therapy, making the HCV-induced liver cancer theoretically curable. In contrast, HBV is more challenging to cure. Therefore, the key to treating hepatitis-induced liver cancer lies in addressing the underlying etiology. In China, esophageal cancer ranks the fourth, and it is mainly esophageal squamous cell carcinoma, ESCC. However, in Western countries, it is primarily esophageal adenocarcinoma, EAC. The high incidence of ESCC in China is mainly linked to dietary habits such as excessive nitrate consumption, while ESC in the West is primarily attributed to reflux disease. Consequently, treatment guidelines for ESC used in Western countries are not suitable for addressing ESCC in China. Given the current imbalance in medical resources and non-standard cancer care in China, it is necessary to develop cancer management guidelines that adhere to the concept of a whole course holistic integrative management and operable in clinic with accessibility at the grassroots level. From 2022 to 2023, CACA organized over 13,000 leading experts to develop the CACA guidelines for holistic integrative management of cancer. This comprehensive guideline, containing more than 10 million Chinese characters, has been translated into 16 languages and include the 46,500 continuing medical education CME questions and answers. It covers 113 topics, including 53 types of tumors and 60 techniques, covering 97% of Chinese tumor patients. By adapting previous guidelines and emphasizing the uniqueness of Chinese physicians, it becomes a standardized guideline system with both Chinese characteristics and international perspectives. The tumor chapter has been adapted in this year, with the technical chapter set for the update next year. China's attitude toward cancer may complement with Western countries. We advocate the concept of a holistic integrative medicine and emphasize the multidisciplinary treatment, MDT, to holistic integrative management, HIM. This involves establishing a multiple disciplinary working model, formulating individualized and integrated healthcare plans, and achieve optimal effects through a holistic view and integrative regimens. Traditional Chinese medicine, TCM, holds valuable insights that should not be overlooked. For example, we found the arsenic trioxide used in the TCM about 2,000 years ago has a great therapeutic effect on acute promyelocytic leukemia, APL. Similarly, artemisinin derived from plants and recognized for its role in treating malaria. Mrs. UU2 has won the Nobel Prize because of it. Now, it has been found that artemisinin can reverse not only bacterial drug resistance, but also tumor cell drug resistance. Additionally, TCM indicated 2,000 years ago that microbiome could be used to treat diseases. If chemotherapy doesn't work for tumor and multiple drug resistance occurs, rather than targeting the tumor cells directly, changing the intestinal microbiota and the drug resistance of tumor cells can be reversed. Thus, our guideline has integrated TCM insights with Western medicine. Foreign guidelines emphasize diagnosis and treatment, while CACA guidelines for holistic integrative management of cancer focus on prevention, screening, diagnosis, treatment, and rehabilitation. It is well known that 1/3 of tumors can be prevented through lifestyle changes. Tumor screening targeted the high-risk population could achieve more efficient results. Also, the follow-up for rehabilitation is very important for the cancer survivors. CACA technical guidelines for holistic integrative management of cancer emphasize both technique and the selection of appropriate treatment for individual patients, focusing on assessment, support, control, protection, and survival. First is assessment. We should assess the patients before proceeding with the surgery or other treatment. The second is support. After the assessment, nutritional and physiological deficiencies should be supplemented to make the patient strong enough to undergo the surgery or other treatment. The third is control. The growth of tumor cells should be controlled rather than simply killing them. The fourth is protection, which means to protect the normal organs. Last is survival. The prognostic effect doesn't only refer to the removal or the reduced size of tumor, and they are just surrogate endpoints. The primary endpoints should refer to prolonging survival time and improve the quality of life. In the last 2 years, we had released and promoted the CACA guidelines nationwide. We had heard over 100 sessions, not only to doctors, but also to the public, with more than 2.6 billion online visits. We also launched Holistic Integrative Oncology, HIO, in 2022, the flagship English journal covering all aspects of oncology research. It is an open access, peer-reviewed journal. Our editorial board comprises over 100 leading experts worldwide, and we welcome more renowned experts to join us. HIO published guideline, commentary, research, review, etc., and no article processing charge will be levied on authors by 2025. To date, 120 papers more have been published in HIO, which have been read over 170,000 times. On November the 14 to 17 this year, we heard the 2024 Chinese Congress on Holistic Integrative Oncology, CCHIO, in conjunction with the 4th International Congress of Asian Oncology Society, ALS 2024, in Xi'an, China, which is a significant platform to promote the concept of a holistic integrative management of cancer as well as the CACA guidelines. There were a total of 252 menus, including the main venue, thematic venues, and the academic sessions. Among these, 50 international sessions were held. The event attracted 60,000 physical participants and around 6,000 speakers. Leading experts from over 100 countries and regions attended this conference to share knowledge and insight. The live broadcast had over 260 million views. During the Congress, CACA hosted joint sessions in collaboration with 10 international organizations such as USCACA, AACR, NCCN, and so on. And we also hosted joint sessions with 5 renowned journals, including British Medical Journal, New England Journal of Medicine, Lancet, and so on. The diverse sessions made this Congress a truly meaningful experience for all aspects. On November 2025, CACA will organize the 2025 CCHIO in conjunction with the World Association for Integrative Oncology, WEO, in Kunming, Yunnan Province, China. We also will adopt this 2024 experience for this meeting. Also, we will have the joint meeting with the top international organization and the more renowned journals, the top journal in the world. And CACA has laid the foundation for developing holistic integrative oncology in China through a series of strategic steps. However, we know, and this is just the beginning, on November 17, 2023, CACA has taken a bold step by launching WEO in Tianjin, China. On November 16 this year, the General Assembly of WEO was successfully held in Xi'an, China, bringing together over 100 esteemed members from nearly 70 countries and regions worldwide. During the General Assembly of WEO, the WEO Constitution was approved and adopted. In addition, the new leadership team was elected. I was elected as WEO president. The new leadership team also includes 9 board of directors from 90 countries and regions. This diverse leadership team will inject a new vitality and momentum into the future development of WEO. While we have been learning and been benefiting from the foreign guidelines, the MDT to him model in CACA guidelines could also reversely benefit to other countries. The 5-year survival rate in Western countries is around 70%, and China's rate reached just 44% through the adoption of foreign guidelines. Previously, the CACA guidelines will help us improve for the remaining 60% and may provide the references for foreign countries to solve their remaining 30%. So that is what I want to say. So thank you very much. Thank you.
Thank you, Dr. Fan, and congratulations on the very heroic development of the guidelines, 100 lectures, billions of attendees. These sheer numbers is what's needed to really tackle the heavy burden of cancer in China. So thank you so much for sharing. Now we bring you our next keynote speaker, Professor Robin Zhang, President of American Society of Clinical Oncology, ASCO. Her presentation topic is clinical oncology progress in the United States. Dr. Zhang.
Thank you so much. Start the slides. Great. So it's a real honor and pleasure to follow the amazing presentations by both Dr. LoRusso as well as Dr. Fan. And Dr. Fan, I'd like to add my congratulations to your recent elections and the work that you are doing. So next slide, please. By way of introduction, my name is Dr. Robin Zahn, and as mentioned, I'm president of the American Society of Clinical Oncology, known as ASCO. My sincere thanks to the China Anti-Cancer Association for inviting me and organizing this summit. So a little background about myself. I spent approximately 25 years providing cancer care to rural communities in the U.S. state of Indiana, and currently I serve as the President Emeritus at Michiana Hematology Oncology, which is a community oncology independent practice, where I previously served as president. I also devote currently part of my time to giving free of charge second opinion consultations with telehealth to patients with cancer as the Director of Breast Cancer Oncology at Cincinnati Cancer Advisors. It is such an exciting time in oncology around the world, and the pace of innovation in cancer treatment and prevention moves faster than ever before, and I am so very hopeful, as the other speakers are, for the future. Today, I'll talk about 3 transformative studies presented at the 2024 ASCO annual meeting with great potential to change cancer care around the world. But first, I'd like to talk a little bit about ASCO. So ASCO is a global network of oncology professionals whose mission is to conquer cancer through research, education, and advancing equitable, high-quality cancer care for patients. We have more than 50,000 members in 170-plus countries and represent specialists in every cancer type, every treatment approach, and every practice setting. 39% of our members are outside of the U.S., including more than 850 in China. ASCO provides timely, trusted information on the latest cancer research and standards of care for the global cancer community, where our vision is to create a world where cancer is prevented or cured and every survivor is healthy. Next slide, please. I'm proud to say that ASCO worked closely with the Asia-Pacific oncology community in a variety of ways. For example, we're grateful to collaborate with the Chinese Anti-Cancer Association and Chinese Society of Clinical Oncology on joint scientific sessions, activities at the ASCO annual meeting, ASCO Breakthrough Meeting collaborations, and mentorship programs. ASCO offers regional programming through our Asia-Pacific Regional Council, which advises ASCO on the oncology needs in the region and partnership opportunities, among other topics. ASCO is grateful for the participation of Professor Jun Ma on the council. We conduct global leadership development programs, which are coordinated through our regional councils and offer virtual learning sessions, small group projects, and in-person workshop. The Asia Pacific Leadership Development Program began in 2021. And lastly, Conquer Cancer, our ASCO Foundation, has a robust grants and award program that has awarded nearly $200 million in research funding to 88 countries, with a focus on improving cancer care and accelerating breakthroughs in clinical and translational oncology research. Next slide, please. The importance of collaboration is one of the many reasons that I have chosen driving knowledge to action, building a better future as my ASCO presidential theme. What I mean by that is converting new knowledge into real change that improves patients' lives. For example, new treatment standards, guidelines, and support tools for practices. That's why I want to discuss the larger effects of 3 studies that were presented at the 2024 ASCO annual meeting. These studies address lung and esophageal cancers, which, as you know, are 2 cancers that are especially common in China. Each of these show how applying new knowledge can potentially transform cancer care. First, I'm going to talk about the impact of personalized medicine on the long-term survival in lung cancer. Then we'll look at the power of telehealth technology to improve patient care. And finally, we'll see how new information is helping settle a long-standing debate in esophageal cancer treatment. Next slide. I personally, in my 25 plus years practice in this community and the years prior to that in training, have seen too many people suffer or succumb to lung cancer in the communities that I've served. However, I am extremely encouraged by the advances in long-term survival and major treatment responses made possible by personalized medicine. So that brings me to the exciting positive results from the LoRa clinical trial presented at this year's ASCO annual meeting. LoRa was the first phase 3 study to investigate a targeted agent following chemoradiotherapy in patients with locally advanced, unresectable stage 3 EGFR mutated non-small cell lung cancer. With there being no prior approval targeted treatments for this patient population, the LoRa trial was designed to fill an urgent need, and the results were impressive. People with EGFR mutated non-small cell lung cancer live longer without cancer growth or spread when given the targeted therapy drug osimertinib after chemoradiotherapy. And that's compared to people treated with chemoradiotherapy followed by a placebo. And in fact, the findings show a median progression-free survival of 39.1 months with osimertinib versus 5.6 months with placebo. So in a matter of months, because of this, the research created a new standard of care for lung cancer patients. And in September, in fact, on September 25th, the US FDA approved osimertinib for this patient population. So thanks to this groundbreaking research and the US's FDA's quick action, people now in the US with unresectable stage 3 non-small cell lung cancer now have more hope and better treatment options than ever before. Next slide, please. But we all know that navigating cancer requires more than just treatment, as you've heard previously from the prior two speakers. Helping our patients live better, healthier lives is central to our job as oncologists. That's why palliative care is critical. And while it can be given at any stage, we all know it works best soon after the diagnosis. Unfortunately, we also know that most patients, at least in the US, don't receive palliative care early in treatment, in part because of a lack of clinicians who specialize in palliative care, but also due to geographic barriers. That is why I'm excited about the results of the REACH-PC study. It found that using telehealth to provide early palliative care is just as effective as in-person visits for people with recently diagnosed advanced non-small cell lung cancer. This particular study used quality of life measurements to compare palliative care sessions delivered via telehealth or through in-person visits. And by the end of the study period, quality of life measurements were the same between the telehealth and in-person groups. What this research does is it highlights the potential of technology, that is telehealth's potential to overcome barriers and enable effective palliative care delivery, providing a much needed alternative to in-person visits. I'm hopeful that these findings will open the door to using telehealth to increase access to palliative care around the world, particularly during early treatment when it could benefit patients the most. Next slide, please. Finally, I wish to share encouraging results from a definitive clinical trial that puts to rest a long-standing debate over which treatment is superior for locally advanced resectable esophageal adenocarcinoma. In the ESOPIC trial, a combination of 4 chemotherapy drugs called FLOT protocol was compared to the CROSS protocol. CROSS is a combination of 2 chemotherapy drugs and radiation therapy given before surgery to shrink the tumors. Prior to the ESOPIC study, the FLOT and the CROSS protocols were both considered standard treatments that offered similar results. Which one a patient would receive would often depend on the country where they received treatment and the resources that were available to them. So perioperative chemotherapy, according to the FLOT regimen, which was tested as superior in the study, is now increasingly being internationally as a standard of care for resectable adenocarcinoma of the esophagus. Promisingly, the trial found that the FLOT protocol helps people with resectable locally advanced esophageal cancer live longer. And in fact, the median overall survival was more than 5 years in the FLOT group compared to just over 3 in the CROSS group. This study could have important implications for global esophageal cancer treatment guidelines, improving and standardizing treatment options for patients. Next slide, please. So when you take it all in, it's really incredible to see the breadth of research progress over the course of 1 year, as Dr. LoRusso had mentioned in her talk. And yet, I can't help but think that we're just beginning to realize the potential of research in these areas. I believe these and other advances in personalized medicine, technology, and optimized treatment standards will lead to even bigger improvements in cancer care for patients around the world. Before I end, though, I'd like to return to the LoRa study that I discussed earlier because it shows the power that we as oncologists have on the future of clinical cancer care and research. Here, you can see Dr. Suresh Ramalingam, one of the lead investigators on the LoRa trial, presenting the results at the 2024 ASCO annual meeting. To me, Dr. Ramalingam's story underscores my belief that knowledge, when applied, is how we will build a better future for our patients. If we look back at his career in 2006, Dr. Ramalingam was awarded a Career Development Award through the Conquer Cancer ASCO's Foundation. This award provides funding to researchers who wish to create their own clinical cancer research programs. Now, 20 years later, patients around the world are living longer because of Dr. Ramalingam's critical research. He received a standing, well-deserved ovation after presenting the findings, and I was there. And that moment stays with me because it shows how promising research powered by passionate oncology professionals like yourselves leads to meaningful impact on cancer care. I hope this inspires each of you to pursue your research passions because driving knowledge to action truly does conquer cancer. Next slide. So thank you so very much. And again, thank you for inviting me, and I look forward to the panel discussion.
Oh, thank you, Dr. Song. Really inspiring speech, and we all feel the passion, and we're so glad to see the progress. Thank you so much. And now, it's my pleasure to bring our last keynote speaker, Professor Agrawal, Vice President of Global Cancer Support of American Cancer Society. And his presentation is Bridging the Gap, Thoughts on Impacting the Predicted Increasing Cancer Burden in the Next 2 Decades. Anu, please.
Thank you so much. It's really my pleasure to be here, and I wanted to also thank the organizers for inviting me to represent American Cancer Society here. Also, as Dr. Zahn said, I wanted to congratulate Dr. Pham and CACA on all the efforts they've made within country and also collaborating with organizations like all of us here today. It's really quite a privilege and a pleasure. Let me just share my slides. So I get the honor of going last, and I think that there were definitely some common themes throughout all of the presentations, which I think I highlighted well in my presentation, really thinking about, as a public health organization, the American Cancer Society has really been focused on how do we improve outcomes for patients with cancer, and we also are very focused on the middle income and high and low income settings as well. So I wanted to talk a little bit about ways that we can work together to improve the incidence, the predicted increased incidence in cancer in your setting, as Dr. Pham also well highlighted. So just to take a step back and give you some information about the American Cancer Society, we were formed in 1913, largely because even at that time, it was known that the burden of cancer was unacceptably high, and we know that's only increased since then. So our vision, and hopefully the simplified Chinese here was okay, but our vision is to end cancer as we know it for everyone, and that includes everywhere in the world, not just the United States. And we do that with really a three-pronged approach through research, advocacy, and patient support, and to ensure that everyone has the opportunity to prevent, detect, treat, and survive cancer, really with the focus on both patients and caregivers. So again, the three-pronged approach we've had is discovery, which is research, with over 450 million grants. We're the largest private not-for-profit funder of cancer research in the United States. Advocacy is really an important aspect of the work we do through the Cancer Action Network to really advocate at every level of government for the support that patients and their caregivers need to receive the appropriate cancer care throughout the cancer journey, from prevention and screening through treatment, as well as palliation and survivorship. And then patient support is all the activities that we do directly to support patients, from helping them to access prevention and screening services, as well as all the support they receive during and after treatment. Globally, we try to highlight some of these same principles. So we work across the cancer continuum in prevention and screening activities, mainly been focused on women's health, specifically HPV vaccination was mentioned by Dr. Pham, as well as cervical and breast cancer screening. Patient support activities, which have largely been focused on patient navigation, which is also well highlighted by Dr. LoRusso. It's such a vital component, which I'll talk a little bit about here as well, to improve access. We have a program called Beacon, which is a capacity development program, which is now in over 32 countries. And we also have a community participating organization in China as well that's participating in that patient navigation capacity development. And then finally, we do a lot of work as well to support providers. We know that providers in these settings work extremely hard with limited resources, treating many, many patients. So a lot of our work is also focused on health system strengthening within the hospital system, as well as to support providers. So I think it was well said, but I wanted to really focus my talk on the increasing cancer burden that we are expecting to see over the next 2 decades, and what can we do together to really make a difference and change that prediction. So worldwide in 2022, there was 20 million cancer cases, and by 2050, it's predicted there'll be 35 million cancer cases. And I wanted to highlight really that the vast majority of those cases are potentially going to impact your environment here in China. So you all are considered a high development index country. And so the rate of increase is going to lead to there being as many cases within settings like yourselves as within the highest income settings. So the burden of cancer is going to be a significant increase for you all. And so this is largely driven by increasing economic wealth. And I'll talk a little bit about this. This was mentioned by other speakers as well. And so although the percentage increase is going to be the most in the lowest income settings, the actual absolute increase is going to affect your setting the most. So it's really an imperative for us to work together to try to make a difference here. So again, highlighting China as a high development index country here in the light blue. And then again, I think really thinking about from a population standpoint, the vast majority of people in the world live in Asia. So the impact that we can have on programs working within country or within region are going to really be the largest within Asia, both South Asia as well as Southeast Asia. This is all taken from the same paper. That's a collaboration between the WHO, IARC, and ACS that's published every 2 years. So this is the most recent publication in 2024 of cancer statistics from 2022. So again, just highlighting China versus other high-income countries. So very similar to other high-income countries as far as the overall incidence. But as China's economic prosperity increases, we're going to see increasing cancer burden to be more similar to the very high human development index countries. So looking at males, that means that the incidence is going to go up, as well as for females. And so although mortality may not change a lot, the overall incidence of cancer is predicted to go up a lot in your setting. So what can we do to really think about stemming the tide so that we don't see this projected increase in cancer incidence? So again, just really highlighting, this is again, overall across the world for males and females, the overall incidence of new cases being about 20 million, cancer deaths being about 10 million, and then the large burden that we see in China, again, as Dr. Pham also spoke to, both as far as new cases between men and women, as well as cancer deaths. And then there's some particularly interesting features that are unique to China that I wanted to highlight, which also Dr. Pham highlighted as well, which are really, really important when thinking about prevention and screening activities for your setting. We have guidelines for United States, but those guidelines don't necessarily apply in all regards in your setting. So it's very, very important to understand how your setting is different and why. I think Dr. Pham also highlighted some specific differences. So as you can see here, in much of the world, the incidence for lung cancer is very, very high, but different than the United States and other parts of the world where the incidence is highest for prostate cancer. Interestingly, though, China is the only country in the world where the incidence for females is highest for lung cancer, rather than most places it's going to be breast cancer. So it's a very interesting finding that's unique to China. And so it may be assumed that this is because of smoking, but in reality, East Asian women have a very low rate of daily smoking. So there are other factors at play here. And so it's very, very important to understand this within your environment. And so similarly, again, so mortality, though, differently than incidence, is going to be more similar between China and other parts of the world, with lung cancer leading, as in the United States, for both men and women. So as mentioned, you would assume that this is a smoking issue, which is possibly the case for men, with 80% of men, similar to the United States, who have lung cancer having smoking as an underlying risk factor. But as mentioned, for women, it's very low, very dissimilar to the United States, where the vast majority of women also are smokers. And so that's a very interesting difference that needs to be further studied and understood. And then again, looking specifically at what types of cancer cases are most likely in China, particularly, as well as where there's mortality, can help drive potential country-specific prevention and screening guidelines. So as mentioned, the incidence and mortality for lung cancer is the highest, but then also thinking about what are the other cancers specifically for China where you have the highest mortality, as well as incidence, and what can you do from a prevention and screening activities to be able to try to decrease that, knowing that without changes in prevention and screening, we're going to continue to see more cancers over the next 2 decades. So really the key message is, how do we work on public health efforts so that we can really focus on these cancers in your setting with the highest incidence and mortality? And I just listed out some of the risk factors that really have to be considered for these particular cancers. And then again, many of these are going to be specific for your setting. So for instance, for lung cancer, we know that given that women are not smoking, there are other environmental factors that are potentially at play. Dr. Fan well mentioned for liver cancer, the risks with hepatitis, also smoking and alcohol. Stomach cancer, H. pylori is a significant driver in East Asia, which is different than the United States and other settings. And then you mentioned also very well esophageal, similar to colorectal, which has a large underlying reason because of diet. So I think it's really key to think about prevention strategies that are tailored to your unique environment. As mentioned, HPV vaccination as well as hepatitis B vaccination are very important modalities to decrease liver and HPV-associated cancers. Cannot underscore the importance of lifestyle modification. Again, really highlighting that as countries become more wealthy, that lifestyle becomes worse, and that really drives a lot of the increasing cancer burden. So smoking increases, poor dietary choices increase, alcohol use increases, and physical activity decreases. So we know this is a big driver as countries move from middle human development to high, and then to highest. And so this is a big driver. And then specifically highlighting again lung cancer, there is likely underlying environmental factors at play, especially looking at women's incidence. So this is just one example that's really unique to your setting. This was from a paper specifically for Asia, East Asia, and looking at some of the differences that really need to be considered when thinking about population screening within your population. So age, a younger onset of age as compared to Caucasians. As mentioned, the prevalence is very high, but very high in non-smoking females. So what are the other potential risk factors beyond tobacco? So food and drinks that may be containing potential carcinogenic substances, air pollution, organic matter, combustion, occupational exposures as well. And so from a population standpoint, very vital to think about how do we work cooperatively with government and other organizations to start to think about other factors beyond just smoking that are impacting incidence of lung cancer in China. So similarly, screening also needs to be tailored to your unique environment. So again, we have screening guidelines in the United States. Some of those may be relevant to your setting, and others maybe need to be included that are not part of the guidelines in the United States. And also, that's really very important to develop organized programs for screening. So highlighting two important cancers within your setting, lung cancer, there really needs to be clear screening guidelines that can be implemented at a country level. And then, as Dr. LoRusso mentioned, opportunities to think about using AI where there is not enough providers potentially. So we know that in the initial studies with AI is very good at reading out negative scans, chest x-rays, low-dose CT scans, and so it can augment the use of radiologists as secondary readers for those scans, which AI may read as positive. Similarly, for gastric cancer, there are no clear screening guidelines, but it has shown benefit screening in other Asian populations, specifically Japan and Korea. And so those are opportunities that could be implemented in your setting to help reduce or to also identify cases early. So we really focus on partnership. I wanted to highlight in 2025, the United Nations Sustainable Development Goal is specifically partnerships. And so there has to be advocacy and awareness around shared goals. And that's really been my focus in starting at ACS, overseeing our global programs, is how can we work together with partners and to share expertise and work towards the common goal of eradicating cancer. And so I was very happy to see this as the 2025 United Nations Sustainable Development Goal. And I think the other thing that we really focus on in the work that we do in other settings is creating linkages, which is also something that is a problem in the United States. And Dr. Zahn spoke to this very well as a community oncologist, really being able to improve linkages between academic centers and community centers, and within other countries, being able to link the community health center where providers need to be trained not only on screening and prevention, but also how to actually increase demand for these services. We've seen this be an issue in many settings where you may have a center where you can do prevention and screening activities, but without education to the community, you're not going to have women and men come in for screening. And so how do you help those community health providers through community advocates to really increase information and awareness so that people are motivated to come in for screening, and also to understand that they have treatment options where they can be potentially linked to a regional hospital or cancer center. And the other thing I just wanted to highlight, which is something that we still are challenged with in the United States, even with all our resources, is that providing cancer care must be holistic, that it has to occur comprehensively in parallel to cancer treatment, and that this still has a lack of prioritization in our setting, and it can affect all income settings throughout the world. And there still needs to be opportunities to further research and implement science to be able to understand and share best practices throughout the world. So I just highlighted all the different aspects that really have to be considered when we say we're providing cancer care. Are we really providing all the holistic cancer care, both to patient and family and caregiver? And again, just wanted to highlight that we know so much more now than we did in the past, that the social determinants of health, poverty, education, where you live, impact the quality of care you receive and your end outcome. And that's a singular focus for all of our organizations, that where you live should not impact, whether it's in the United States or globally, should not impact your outcome. And so there are many, many pieces, though, that need to be addressed to really be able to affect significant change. I'm going to skip over a few of these slides just for the sake of time, but they just highlight many of the issues, the themes that patients face. We use the word survivor when a patient is diagnosed. When they diagnose, they become a cancer survivor throughout their cancer journey. And it just highlights many of the areas of need beyond just the receiving medications, radiation, and surgery. And then also all the factors that impact health equity beyond the patient, both at the healthcare provider level as well as the system level, and how we can think about solutions at all of these levels to really improve access and equity. And I was going to talk a little bit about navigation. Dr. LoRusso also did a really nice job of highlighting how important navigation is. And we've really seen in the United States more and more evidence over the last 30 years that even in a high income setting with a lot of resources, there's many gaps in providing equitable access and care to cancer patients. And navigators, we were very happy through the work our organization and others did to advocate such that navigators are now compensated through our medical insurance system. But still, there's a lack in many community centers due to lack of resources to be able to have navigators who can support patients through all parts of their cancer journey. And so globally, that's really been a large focus for us, is really helping to implement navigation programs, knowing that in many settings, it's even more important than the United States, and really working collaboratively now. We launched a Global Alliance for Cancer Patient Navigation to really work together on implementation strategies, but also implementation science research that can be published jointly so that we can continue to work on helping countries establish programs and also build awareness so that navigation can become part of more of a national cancer control policies throughout the world. So we really see that navigation as a way to identify barriers and to come together with patients wherever they are in their journey and provide the information they need. I just skip over this, but this is some of the information. This is a paper that was published by Professor Chan, who's in Australia, who we're collaborating with regarding some of the evidence, which is really limited to high-income settings. So part of our alliance is with the goals with other organizations to continue to further this work in other settings beyond the United States. And again, just focusing to our work with navigation has been largely in the treatment setting. A patient gets diagnosed, how do we help them have the appropriate information and resources to complete their cancer treatment journey? But navigation is really a tool that can help patients throughout the cancer continuum, from prevention and screening through treatment and survivorship or palliation, end of life, as well as to build awareness on the individual needs of patients. And then I just wanted to highlight again the important role of caregivers, both family members as well as non-family non-family members who are caregivers. They are equally impacted as the cancer patient, and their role is incredibly important in supporting the patient through their journey. And so I think that any system that is put in place to try to address all of these multitude issues that the cancer patient is going through also have to be thought about for the caregiver as well. I think I wanted to highlight lastly too, the healthcare providers in these settings, as I mentioned, are incredible stress and work incredibly hard. I've met so many devoted healthcare providers throughout the world, and as much as we can support them so they continue their work in their setting is incredibly important. So I think we have an amazing opportunity, as the other speakers highlighted. Research is moving dynamically fast. But from a population-based standpoint, we have to really think about this predicted increase and all of the solutions that can happen proactively together to really impact this prediction model and make it much less than what's predicted in the next 2 decades. Thank you so much.
Oh, great. Thank you, Anu. Really, thank you for the comprehensive discussion. And I think a holistic approach has been mentioned a couple of times during this discussion. So now it's really exciting. For myself, I think this is the most exciting and the fun part of our summit is a roundtable discussion. And also to report, we have about 16.8 million attendees online watching this and listening. So I'll start the question. I think there's a common theme that we discussed. I believe everybody mentioned AI during your speak. And I want to just ask, how would AR going to impact clinical practice, clinical trials, oncologist patient interactions, etc. And more specifically, in early detection and the diagnosis of cancer, pathology, liquid biopsy, etc. And also in optimization of treatment. For example, what would be the best neoadjuvant treatment option for a particular patient when he or she was first diagnosed? And also, how would AI assist multidisciplinary approach, or provocatively, will AI replace oncologists? So who's going to start?
You want me to start, Dr. Yan?
Anybody? Yeah.
Well, I don't think that AI is necessarily going to change or is going to do away with medical oncologists. I think that it will greatly assist us, and it may change how we do things, and hopefully for a significant better. You know, I believe right now, I mean, we've come a long way in oncology since I first started many years ago when we only had 5-fluorouracil essentially for the treatment of cancer in terms of chemotherapies. But we have a long way to go because I think all of the speakers have pointed out there's still a lot of people dying of this horrific disease. So looking at it even from a neoadjuvant or adjuvant perspective, right now, the data that went into the neoadjuvant setting for lung cancer, as an example, using immune checkpoint inhibitors plus chemotherapy, there were a significant percentage of patients that probably didn't benefit, but that the way the trials were done and with the limitations of no biomarkers of any meaning, we really treat everybody with the same therapeutic intervention. And unfortunately, we may be preventing them from going on to better clinical trials, as an example, because we're giving them standard of care instead that may not be optimal. So I think AI is going to move quickly. I think it's going to make a difference in terms of drug development. I mean, we saw, like I said, the Nobel Prize in chemistry. I think that may help us be able to define the amino acid structure of transcription factors, which I think are going to be the most important, very important in drug development. I think it's going to help us put all the data together. We're getting reams of data from patients, and we don't always know the best way to put it all together. But the algorithms are going to be important. And the differential in patient populations that are going to be required to go into those algorithms, I think, are also going to be important. I think with the sophistication of what we're doing, we need to go beyond personalized medicine to individualized medicine. And that's going to take a lot of work. And I think that we're going to need sophisticated AI tools in order to get us there. But we're at our infancy right now.
Thank you.
I can add a little bit.
So AI will help us, and AI is not going to replace us.
I can add a little bit. I think I'm sure many of you have seen the studies which showed that the AI does better than humans with some of the emotional discussion around cancer treatment, which is interesting and somewhat not surprising. But my hope is that AI helps to reduce the burden that the oncologists have, allow them more time to be able to have some of those meaningful discussions. But I think the use of AI is going to really help patients have hopefully also more equitable course. AI has the opportunity to help with improving the diagnostic quality so that all patients have the opportunity to get an accurate diagnosis. And then also same with treatment, helping to ensure that patients receive the appropriate treatment, being able to keep up with the literature, as Dr. LoRusso mentioned, and also connecting with clinical trials. I think that utilization of AI tools can really help with that somewhat difficult process now, is actually connecting the patient with the appropriate clinical trials. So yeah, my hope is that AI will really provide augmentation of the quality care that patients receive. And in all settings, in the low and middle income setting, AI really provides an opportunity where there aren't providers to help fill a gap that's a little bit different than in higher income settings.
Great, thank you.
So just to add to that, if I may, I agree that AI will never replace a clinician, but it is meant to augment what we do every day by not only potentially accelerating research and improving patient care, but as has been mentioned, improving the efficiencies. As time goes on, as we've seen in the discussion, the cancer burden is going to increase, not only by new cases, but also by the joy of our survivors, unfortunately, getting second and third and fourth cancers. So we're going to have to be able to do more with less. AI is a particular technology that might be able to help us, but I would warn and caution all of us that's on this call is that ASCO and other organizations and the people sitting in this room in this panel discussion are concerned about perhaps increasing health disparities and undermining equity with AI. So therefore, guardrails need to be put in place. And certainly we're lacking systems right now that can evaluate and validate the AI models to make sure they're safe for use. I would be remiss if I didn't mention that ASCO in May of 2024 published our 6 guiding principles for AI on oncology to provide a blueprint for responsibly using AI to benefit patients. And primarily it centers on transparency, informed stakeholders, equity and fairness, accountability, oversight and privacy, and human-centered application. I'm very enthusiastic because AI has been used in other industries. It's being used in science, it's being used in business. We're a little bit slow in having to adopt AI, so we can learn from other industries what worked and didn't work. But we have specific needs, and we have a specific population that's different. And so I think with collaboration globally, and bringing all the diverse expertise, but putting the guardrails in and acknowledging that with power, sometimes there can be risk, and that we need to go in with our eyes wide open if we're really going to facilitate and transform medical care for our patients using AI.
And you have to, you also worry about the reproducibility of the tools or the reproducibility of the data that comes out of the different tools. So I think not only are we going to be using it in the future, but we're going to have to study it, I think, in controlled settings in order to use it. It reminds me, I was watching the news yesterday, and they were talking about, workers and how many times in select scenarios, many workers were very concerned about automation, and how automation was going to overtake their jobs and just, and they were going to be left without jobs. But actually, automation has created more jobs, but different jobs. So we have to grow and advance with as we automate. We have to grow and advance as we bring AI into our toolbox.
All right, let's invite Dr. Ben to talk about AI in China.
Yes. So, I'm a clinical doctor. I major in the clinical medicine I'm over 70 years old. So I was told the AI is very helpful in the clinical medicine. As I always to buy the AI maker or AI creator, but it's a tool by the clinical doctor. So that means it's maybe at this time, it's at this moment, it's too early to say. So AI can do so many words, so difficult problem in the clinical medicine. So, but I'm not the conservative, but I think AI it's useful at the moment. Is to up to now a lot of comprehensive number of the data, also the papers that come to me. So I don't know which one is correct or not. It's a fragmented data. So we can use the AI, firstly to analyze, then to give us a conclusion, then we can test that this conclusion is right or not. Then for the future clinical medicine, it's better. So up to now, so I think to believe doctor more than AI at the moment in the clinic medicine. Other words, so for example, Dr. Ying, if you want to say, if you have some suffering, so if you want to come to doctor or to AI, so that is a very that is my question. No, my answer. I'm not a conservative. I mean, it's the AI for other science, scientific field, no problem. For medicine, especially clinical medicine, it's a too early stage. So we want to develop them then we can use that. Thank you.
Great, thank you. So we need evidence, evidence, and evidence. Yeah, great. So maybe we could come back to Dr. LoRusso because we mentioned that AI may be helping, for example, when you see your patients, how to match a particular patient with appropriate clinical trial. I know you know all your trials in your mind, but for other, your peers in other settings, community settings, for example, they may not know all the clinical trials. So in that scenario, how would you picture AI could help your community oncology colleagues to match their patients to the most appropriate trial that patient could benefit?
Well, I'm not an AI expert by any means, but currently I'm working with a bioinformatician. And at our institution, we have 15 community practices that are under our umbrella, and they all belong to the same Epic electronic medical records as well. So I'm working in tandem with a bioinformatician who's developed an AI tool. And what he's doing is he's going through the electronic medical records. He's developed a tool to go into the EMR, and we identify specific characteristics of each particular trial, for instance. And what he can do is he can go into the EMR and he pulls for us within hours, based on the entire EMR system that we have in our institution, all potential patients that may have that alteration that fit the inclusion-exclusion criteria. So we're starting to do this, and it's quite successful. Even though we may be late to the game in terms of opening our trials, we can identify larger populations, especially with rare molecular alterations. But then now what we do is we take that data and we go to their oncologist and we ask them if we let them know about the trial and ask them if they'll send us the patient or enlist the patient on the clinical trial. So I do think that AI is going to help in that. It's helping us already.
That's great. It's really streamlining.
It's an internal program that one of our bioinformaticians has developed, but there's other AI tools for patient matching that are currently being developed as well. I mean, Robin may know of some that they're using in the community, and I don't know, but.
So that's certainly a challenge. If you have community sites that are within a network, that type of program that you're developing could be very helpful. But the challenge will be in rural communities where you're really disconnected, or you're independent and you're semi-rural, where I am, plus the rural. And the question is really, is there a larger solution? And I could envision that one of the big challenges, as you mentioned, Epic, is not everybody has the same EHR. So the patient should be able to have their access to their records and go to a platform. That platform would have that AI tool that has the research study that can do the matching, for both the provider and the patient. So it's a much larger solution. But what you're doing, Dr. LoRusso, can serve by example as a model, of how that AI can be used to do the matching with clinical research. There's a lot of work that needs to be done, clearly.
A lot. We're at our infancy with it.
But it's fun to think about the potential, because I think that, the challenges that we're facing in the community setting is that, as I had already mentioned, everybody has a different EHR and they don't talk to each other. And within the rural community, especially, and even in the city for that matter, I just saw a patient from Cincinnati today that went from one system to the other, and yet the records were lost. We were missing information, and you need that to be able to do the clinical trial matching as well as to do individualized care. So there's a lot that needs to be done, but I would think, and I'm just throwing that out as an idea, is that we need to have a platform that's unbiased and able to take the information for the patient, no matter where that information comes from, and democratize.
Yes. Yeah. I mean, if you think about it, for other industry, appears that they already solved the problem. They should be able to have the data flow from system to system, but for
the problem we have,
it's being a nightmare.
Dr. Yan, the problem we have in the United States is exactly what Robin said. There's way too many platforms. If you go to a country like England, where everybody's part of the national health system, the NHS, everybody's record is accessed. They can identify patients all over the country.
Yeah.
because they're using
Iceland.
the same they're using the same electronic medical records. So, I mean, we have a challenge in our country because it is a privatized healthcare model.
Dr.
Yeah.
Fan, in China,
yes.
what is the situation with electronic medical records? Are hospitals using the same standard system or diversified different systems?
Yeah, so it's in a different hospital, their level is not the same. So I would like to add also emphasize the AI is helpful for the medical development. You know, in China, so in the cancer field, our strategy and the slogan is cancer control, winning in integration. So how to integrate what we should integrate. We know so the digital data can integrate it into the information. Information can to integrate it in the knowledge. Knowledge is not power. Only integrated in the smart. Smart can solve the problem. So in China, this is our CACA guidelines. You know, we organized 13,000 people's idea. So how to integrate it is by AI. So the human body, a human brain cannot solve this problem. So our the CACA guideline is a comprehensive guidelines by the AI. So that means help us. So I have also I have a question to the Robin Ying. Also, it's for your former the president, Dr. Wang, right? So you know, China's CACA guideline. So it's integrated to all fields, not just focus on the drug treatment, but also the surgery, also the prevention, screening, and the rehabilitation together, including also that integrated with the basic researcher and rehabilitation and so on. So we our CACA before usually we organize this reorganization gets just like a U.S. reorganization together to solve the problem. So the drug only the medical treatment is just one of a field should be under umbrella of the comprehensive the different the treatment style. So I was told in this year, so ALS has collaborated with you in Yokohama, has ASCO through, right? Breakthrough, right? So my question is, do you have some idea or suggestion to collaborate directly with the CACA in the future? So I'm sorry, could you hear me?
Yeah. And who this? I mean, this question is for ASCO, AACR, or ACS?
ASCO. So, yeah,
okay.
To the group in June, because they are mostly focused on the cancer treatment by drugs, by medicine, right?
I'm missing a part of the question. I'm sorry, Dr. Yang, could you repeat that for me?
I think the question is Dr. Fan is asking how ASCO guideline versus CACA guideline could be learning from each other. Is ASCO guideline mainly focusing on cancer treating medicines? Is it also comprehensive, including surgery, radiation, etc.?
I see. So, well, it depends. We try to be multidisciplinary, in our guidelines. And, certainly there's bi-directional, learning that needs to occur. And we do have resource-focused guidelines. So, for example, we have guidelines that have been developed for lower middle income countries that may not have the same resources as the U.S. But certainly, I think there is always room for improvement, to be more comprehensive, in the guidelines, although we have multidisciplinary representation in our guidelines, as we develop them.
Okay.
Did I answer the
Great.
question?
Yes. So how to explore the collaboration with you, the CACA means the CACA with you, with your ASCO, or also ISMO, because you have a different environmental, also the genetic background. So how to collaborate the complementary, for the complementary the guideline to benefit not just the Western country, but also its benefit to China.
So I think you bring up a very nice invitation, to have further discussion to see how could this be facilitated.
Okay, so in the ASCO guideline, also the ISMO guideline, I was read about 5 years ago, only 4% or a little bit more from China, the data. And so now it's more and more. So the CACA guideline now it's embodied around the 20% of data from China. Now, for the second edition, it's 40% for China because the environmental and the genetics is quite different. It's also, we have clinical experience. We put them together, including traditional Chinese medicine. So this is, of course, we are cited a lot of not of data and not of regulation from the ASCO. So we want to do complementary the CACA guidelines. That is what I want to do.
I will take this back to the ASCO leadership for you.
Okay.
Okay, sounds like we have a topic for next year's 2025 meeting.
Yes.
CACA, ASCO, NCCN, ESMO, clinical oncology guideline. That will be a very interesting discussion and a topic for next year.
Very good suggestion. Very good suggestion.
Great. All right. This is a great discussion. So now I want to come back to patients. I think the reason why we're all here with 17 million people online is really discuss and talk about how we go to provide the best care for our cancer patients. So whether it's in US or in China, I would believe that most of the cancer patients are cared for by their community oncologist. So Dr. Zong and I, we discussed this before this summit. How do we really convince the patients to stay with their community oncologists and practices? And how do we really convince these patients so that they could get their care equal quality and get the same resources and the same quality of care close to their home, which is much more convenient? So to achieve that, what do we need to do? What do we need to provide to the community oncologists and practices? And what do we need to provide to the patients so we could convince them stay close to home and get the care they needed? So Dr. Zong, I will invite you to start because you really did a great job in serving the community patients.
Well, thank you. Thank you very much. So, of course, I come into this conversation biased because that's what I do is community medicine. So I will put that up front. But, clearly there are, many cancers that as community doctors, we take care of our patients very, very well. We use guidelines, we use pathways, which oftentimes, if not almost exclusively, have been developed by the experts in the fields. So whether you use ASCO guidelines for breast cancer treatment, or I think you mentioned NCCN, or other guidelines, these have been vetted. And so oftentimes we will go to those guidelines and look for assistance on how to treat our patients. And we tell patients that, and we provide them that information. But we also acknowledge the importance of having relationships with major academic institutions that are within our reach. So if patients did want to go, they could go. But we supplement that by having a phone call. We talk to the doctors there, or we refer their cases, and they will have a panel discussion or a tumor board review without the patient necessarily traveling. Or if we feel ourselves in our own tumor board review that perhaps we need to get second opinions, we are always very humble in the sense that we maybe do need to have another pathologist look at it, or we have to have a radiologist for an academic center. So we work collaboratively with each other, both at the academic institution, but also validation by the academic institutions of the care that's being given at the community center is also very helpful. And so we would invite, speakers from the major tertiary cancer centers to come and speak to the community about some topic, some particular cancer, and they, could share, their experience in working with us. We do clinical research, with the academic centers, and when they hear, oh, so you're doing it with Dr. So-and-so from some institution, they feel like, okay, it's a validation process that, okay, you are striving to give the best care possible. We have quality metrics, benchmarks, that we try to achieve through a number of mechanisms. Our practice through ASCO, did COPI, for example. Now there's something called ASCO Certified, which is a care delivery model, that is exemplifying and is accelerating equitable patient care by promotion of the highest quality of care possible. So there's all these different mechanisms in place to be able to assure that we're delivering, care. And, and certainly, we use telehealth. So I mentioned that as a sideline of, besides being ASCO president, I also give the second opinion, free of charge second opinion consultations for breast cancer. And I entertain all patients that want to come, and we review their records together. And then we, share with them what our expert opinion is. And sometimes we even say, maybe you need to go somewhere else because it's so specialized and your need is so unique that we recognize that. So I think at the end of the day, if you look at the number of survivors, and you look at how many patients are treated in the community, part of the reason why there's all those survivors is the community is doing a good job, in taking care of those patients. Otherwise, we wouldn't have all those 18 million survivors that we talk about. But it's by using collaborative, knowledge through the guidelines, as I mentioned, and pathways, and being able to rely on each other to get the expert help, and and clearly acknowledging where you have weaknesses is important. So, for example, I may suggest for a particular rare tumor that they do try to make the trip, to a tertiary care center if at all possible, if nothing more for a first visit, and then get the remaining of their care back with us, and then we can contact the doctor and have an ongoing relationship. So I've said a lot of things, but I think there's plenty of opportunity, and there's proof that this can work, and it works very well. I do want to mention that ASCO has a rural Montana project, which is certainly underway, that's looking at a particular model, looking at a very, very rural site in Montana, where those patients were having to travel through horrific weather, oftentimes not even being able to make it into another area in Montana to get their care, where we're transferring their care into a very small community. And part of it is because there's commitment. And that's a key part of it, is commitment, not only from the providers, but the hospital administrators in the community to be able to give that care in that area. And I didn't say that, but that's very important, is having the support of the community to be able to deliver the care in the community setting for the patients.
Great. Thank you so much.
So,
In the United
Dr.
States, I think it's over 88% of all cancer patients are treated in the community.
88%. Okay, Dr. Wang.
yes. Okay. So, in China, I think the cancer patients can be treated in the local hospital and the community hospital. First, the government pay a lot of attention to build and develop the local and community hospital. So each community has their own community hospital. And we also how to treat the community oncologists or doctors. So we promote the CACA guidelines to the local hospital and train the doctors. Last year, we have trained the local doctors on the CACA guidelines for more than 4,000 events. And we also have the doctors from the specialized cancer hospital or the biggest general hospital doctor go to the local hospital or community hospital to help the local doctors to treat the patients. So the cancer patients, when they come back to the community hospital, the community hospital can give them basic treatment according to the protocol given by the specialist in the cancer hospital. So they have equal treatment when they are in the community hospital and in the cancer hospital. So the patients also can get the treatment, also can get the control of their side effects and some of the other problem. So I think all patients, because in China the survival rate has increased than before, and we have a lot of more and more survivors. So we must pay a lot of attention for the survivors' care. So that's why we promote the CACA guidelines to the local hospital to train the community oncologists and the doctors. So that's why we can give the patients more better treatment, and also can make the patients more convenient to get the treatment. So I think since the CACA guidelines developed, the patients get a real benefit to the patients and the survivors. Okay?
Great. Thank you, Dr. Fan.
Yeah. So Dr. Wang has told us, told you that how to do that. Could I add the one sentence? It is so we will thank the media, especially public media. So by the media, they release and promote the CACA guideline, also scientific knowledge to the community, also the doctor. It's a mutual to promote the outcome of anti-cancer. So, anti-cancer movement, 10 years ago in China, the 5-year survival rate, only 33%. The 10 years has passed it. And last year is 43%. So, the incidence of cancer is each year is around 5 million, right? So that means the 500,000 of the people, that is 10%. So survive more than 10% of the survival. They got the 5-year rate. So that is the government pay great attention to our CACA now has do something. Also, we were thanks the media, especially, for example, today, why we have so large number of the audience, more than the 70 million. So that is the media's rule. So we were thanks that the media, so many medias. Thank you.
So amplifying the guideline and really settle them to the community level, community oncologist level. That's great. Dr. Agrawal, I saw you raise your hand. Yeah. please.
Yes, I just wanted to congratulate CACA for their work in this particular area, and that the improvement in outcomes too is really quite remarkable over such a short period of time, and the impact, of course, is so huge. So congratulations. And I think the comment that Dr. Wang made is really important, and that creating that linkage between the community health provider and the larger academic centers is really incredibly important. So there's ongoing discussion for those difficult cases, and that's something that we continue to work on here in the United States too, as more centers need additional help. The therapies are becoming more complicated. The change as far as new treatments is becoming more rapid, and being able to learn all of that information and then know what's best for your patient is increasingly difficult at the community level when you're seeing all types of cancers. And so I think that issue is going to become more and more a challenge for the community provider to be able to keep up. So creating a system where you have clear linkages is really important, as the vast majority of patients, as mentioned, are being treated in this setting.
So very quickly, just out of curiosity, Anu, for ACS patient navigation, what will be the first recommendation? Does it recommend that he or she, once diagnosed, to go to the community oncologist or seek a second opinion? How does that work?
So our job really is to train navigators, both lay navigators who help with the resources, as well as nurse navigators whose job is to provide education and resources to patients and their caregivers. And as was stated by others, especially Dr. Zahn, we fully support the patient's best interest, which is going to be being treated as close to home as possible from a resource standpoint and just a quality of life standpoint. So we've been really most focused on supporting the patient, and we have not necessarily as an organization been as focused on the treatment piece. That's more for other organizations. But of course, these are intersecting issues because we all want to ensure that patients receive the best therapy. And so this is an issue that we think is important for us to work on collaboratively. So through some of our roundtables discussion, which we're starting a hematology roundtable next year, really to focus on this issue is how do we work together to improve diagnosis, treatment, and access to clinical trials for all patients in the setting where the diagnoses are changing rapidly, pathologic diagnosis can be challenging, and then the treatment options are changing rapidly too. So I think that's something that we all need to collaborate on together to ensure that patients receive the optimal therapy in their local setting.
Great. I know time flies, and we have many topics we want to discuss. So we have about 5 minutes. I would like to ask a last question to each of you, because you all represent a major organization fighting cancer globally, and you also have power to influence policy. So if you need to influence one single policy in 2025, what would be your choice? Funding? AI? Anything else?
Yeah.
Who wants to start?
Can I say it, right?
Yeah.
Cancer control winning in integration and collaboration.
Okay, great. Dr. Zhang?
It's all of it.
I know. I was like, which one do you go for?
I was going to say, we have our fingers in everything at the federal level, the regulatory level. And we didn't mention in the US, we have the opportunity at the state level. Because in the US, the federal government may legislate law, but it's administered at the state level. So the advocacy also is very heavily, as it should be, and equally designed for the states to be able to pass legislation to help benefit our patients.
Great.
So,
All levels.
I think I agree with her all levels, but there are a couple things that I think are really, really important to continue the progress that the positive trajectory that we're currently on. I think funding is crucial. And a concern in the United States is decreased funding on the government level because the government in the United States funds more cancer research than any other organization in the United States. But there's also another point that I think is very important, and it's education. More and more, the lay public is becoming leery of science. And I think it's important to find different venues to not only educate the clinicians, the nurses, the healthcare professionals, but all the lay public. Because the more we can educate them on the importance of prevention and, treatment, et cetera, the better off I think we'll all be. And I think we need to get to them, and we need to figure out a way to educate them so that they trust us, that they trust the educators. And if we shy away from that education and that trust, we're going to be in trouble. And already in the United States, we know that vaccines, as an example, are very, very important to prevent diseases, HPV, cervical cancer, head and neck cancer, etc. But there's a moving trend in the United States of people who are not believing in the science. And that's frightening to some of us, because that's the only way we're going to make progress, not only to educate the educators and the caregivers and the healthcare providers, but to educate everybody.
Well put.
I think the very important thing is international collaboration.
Yes.
And Dr. Patricia said, in United States, the funding is in decrease, but in China now, as I know, the funding is increase. So I think the international collaboration is very important, and the academic exchange is very important.
Oh, extremely.
Like today, we have learned each other, and we learn a lot from United States. And maybe you have learned in China's way how to prevent the cancer or treat cancer. And the audience is over 70 million. So it's not only we benefit from the exchange, but the audience also gain a lot of knowledge from China and the United States. So I think international collaboration and exchange is very important in the future.
We in the United States recognize the importance of China right now. In oncology, some of the most innovative drugs that we are also developing in the United States have come from China and have been developed in China. We need to collaborate. The world is becoming smaller in oncology as it becomes more sophisticated and developed. We need to work together. I agree with you, Dr. Wang.
Yeah, and I also want to support what you said, Dr. Wang. We, as a global organization, recognize the globalization of cancer. So there are certainly diversities, so there may be differences, but there are also very common themes. And being able to become efficient and to collaborate and bidirectionally to maximize what's common and make it very efficient, but also acknowledge at the same time the potential differences, and not to ignore it, but to embrace it and be able to better understand it and develop the evidence to be able to deliver the care to address those individual needs is very important. And ASCO fully supports what you're saying in terms of international collaboration.
As well as AACR. Right. I mean, like I said, we need to work together.
Absolutely.
The enemy is cancer.
Exactly.
Soldiers that are going to work together to create the army that's going to kill the enemy.
That's right.
Yeah.
Great. Right. Thank you so much, Dr. Agrawal.
Yeah, thank you. So it's hard to pick one thing. I think, as was stated by others, it's hard to pick one thing. But from a public health standpoint, really looking also at the World Health Organization, WHO best buys, globally, where we can have the most impact with the highest return on investment is in prevention and screening activities. The more that we can prevent cancer and the more we can screen patients early, where they have the highest likelihood of cure. So from a policy standpoint, whatever we can do globally. So for instance, HPV, as Dr. LoRusso mentioned, we have an opportunity to globally eradicate HPV-associated cancers. If we came together globally, we could do that. Australia will, in 2028, is predicted to eliminate cervical cancer as a disease within Australia. So I think those are opportunities that, from a return on investment standpoint, should be the forefront of policy decisions. And you know, tax and vax, we always use the word tax and vax, like taxing cigarettes. That's a simple strategy that makes a huge difference that can really impact incidence.
Well,
Thanks.
this is great. This being, I can't believe it already passed, the 2 hours have passed. I want to thank each guest for sharing your insights and inspiration in fighting cancer. And I also want to thank the organizers, CACA, U.S. Chinese Anti-Cancer Association, as well as World Association for Integrative Oncology, and our co-organizer, eChina Health. I also want to thank 17 million of attendees online for your interest and support. Together, we will defeat cancer. So happy holidays and bye for now.
Thank you so
Thank
much.
you.
Bye-bye.
Thank you.
everyone.
Bye-bye.
Thank you.
Bye.
Thank you.
Bye-bye. Thank you,
Bye,
everyone.
everybody.
Bye-bye.
Bye-bye.
Bye.